Great. Yeah, hi. So if folks could drop like name, the kind of work you do, like your org and where you're joining the call from, that'd be great so we can get a good sense of who is here joining us today. Is the chat? Yeah, the chat's open. Okay, cool. Great. Well, as those start pouring in, I see we've got some folks from quite a few different states. I will give you guys a little bit of background about myself and about the Washington AIDS Partnership. So my name is Reagan Dunham. I use she, her pronouns. And I am the Health Equity Manager here at the Washington AIDS Partnership. The partnership was founded in 1988 at the height of the AIDS epidemic in its early years. And it was founded as a funding collaborative to kind of pool money together from national grant makers and then give it out to local organizations. And so since the 80s, it's expanded into more than just grant making with like youth development programming and the program that I manage, which is called She Comes First. And it's our program here that integrates sexual and reproductive health services. And this training specifically got started, I got the idea for it a couple months ago, right after the Dobbs decision came out, because I was devastated, as I'm sure everyone else was. And I was really thinking about the organizing that I've done both in this job and outside of this job with the Decrim Poverty DC Coalition, which is trying to get the city to decriminalize substance use and open up a 24-hour harm reduction center. And I was noticing how with the criminalization of how people choose to end pregnancies, a lot of that can correlate to criminalization of other behaviors during pregnancy, such as substance use. So I was thinking of ways to integrate reproductive justice and harm reduction. And fortunately for me, there were some wonderful people already doing this work. So on that note, I'm going to pass it off to Joelle.
Hi, everybody. Welcome. Welcome. Thank you so much for being here. We're really excited to have our final event. In some ways, I'm more excited than for the other ones because we get to hear from all these amazing experts. I gotta hurry up and get my stuff done so that we can hear from these folks who are with us today. So real quick, the Academy of Perinatal Harm Reduction, we do all kinds of things. I always struggle to be like, what kind of an organization are we? Our mission is super broad, and that's on purpose. We want to improve the lives of pregnant parenting people who use substances. And we do that primarily through education. We also have a lot of ideas about like more outreach and direct service stuff. But please check out our website. It's perinatalharmreduction.org. We have in about a week or two, we're having our updated version coming out with some new research updates, as well as it's going to be available in Spanish in addition. So our goal is to have communities where families are safe, intact, and informed. And we don't think it should matter what you put into your body. Everybody, the composition of their blood or their urine. We'd like to do an Indigenous acknowledgement. If you were here for the previous two, you're hearing this again, but I think that we can't say it enough. So the first time I spoke in the Baltimore, DC area, I had the pleasure of being able to have a conversation with Natalie Standing on the Rock Proctor, who's the tribal chairperson of the Cedarville Band of Piscataway Indians, or Piscataway if you're local. She said both are acceptable. Basically, it was a hard conversation to have because Natalie had stopped accepting invitations to events because she felt like people were just using her to check off a box and prove how good they were and how they're paying attention. And then they didn't really, nothing ever came from it after that. The cultural center closed due to lack of attention, and they stopped doing the Living the American Indian experience because non-Indigenous people really don't want Native people to be whole and to be present and to be current. People wanted them to be, you know, cooking over fires and wearing feathers and the parts of history that are ugly to look at, which are a huge part of history for all of our North American Native Indigenous nations. They also found that people were uncomfortable with the idea that Native people are here and are active in tech and fashion and all these kind of more modern enterprises. And so I just think it's really important to acknowledge all of, you know, everybody wants to be acknowledged as a whole person and not just the parts that are palatable or just the parts that are, you know, cute and nice to look at. And so as we acknowledge Native nations as present and here and as composed of whole people with various facets and different needs, I would like to invite everybody on this call to make a donation today, please. It can be $1, $5, whatever you can afford. Please go to PayPal, and the email address is piscatawayindians@gmail.com. And please just make a small donation today to our Native neighbors. With that, we will get right into, oh, thank you for sharing those, Reagan, the links. We'll get right into it. First, I would like to invite each of our speakers to do a brief introduction of themselves and their connection to this work. And I think just in order to make things go smoothly, let's go in alphabetical order by first name. So let's go Anna, Benjamin, Lauren, and then Mishka. Take it away, Anna.
Hey everyone, it is a privilege and pleasure to be here. I'm seeing some familiar names in the attendees list and just welcome. My name is Anna. Like I said, I am staff attorney and legal director at Elephant Circle, which is based in Colorado. Our mission is, well, we're inspired by elephants who give birth in a circle of support that is also a circle of protection. And we are advocates for birth justice, which we believe is realized when every person has access to the tools that they need and the support that they need in order to live self-determined lives with dignity and respect. And so, yeah, my entry into this work is both personal and professional. I started learning about abortion criminalization and specifically the criminalization of self-managed abortion when I was navigating my own home abortion several years ago. And just in learning the sort of legal landscape of that form of criminalization, started learning a lot about the criminalization of substance use during pregnancy, and seeing intersections between the ways that those two sort of forms of criminalization were overlapping and coming from the same laws. And since then have really just continued to love working with advocates like the folks who are on this panel, and in community with people who are leading this work at the ground level, at the grassroots level. So thank you so much for including me.
Hi, nice to see everybody, although I can't actually see you, so nice to kind of sort of see you. Anyway, my name is Ben McMichael. I am a law professor in Alabama at the University of Alabama. So when we talk about criminalizing pregnancy, ground zero. So I've been working on the laws and regulations around criminalization of pregnancy. I think the way these fine folks found me, I wrote a paper with another professor who's now at Wake Forest on the criminalization of substance use during pregnancy. It was Tennessee's law. Now I'm working on Alabama's laws, which are more nuanced and surreptitious than Tennessee's. I don't really have a lot of interesting things to say about me. I am both a lawyer and an economist, which is great because no matter where I am, no matter who's in the room, at least one person hates me on principle. So got that going for me.
Hello, my name is Lauren Quick-Graham. I am a licensed clinical social worker, licensed clinical addiction specialist in North Carolina. For the past 12 years, I have been working in perinatal mental health, mostly in substance use treatment and recovery for pregnant and parenting individuals. I have worked in the prison system with the pregnant folks there. I've also worked in residential treatment, detox, and outpatient treatment. And I also have experience gathering and disseminating maternal mortality data for the state of North Carolina. And as many of you already know, the CDC just released data that says that the leading cause of death, maternal death for all overall, is mental health conditions, which includes overdose deaths. So I'm very happy to be here. I'm glad to be here to talk about this really important issue and something that I'm extremely passionate about.
Hi, thank you for inviting me, and it's really a pleasure to be with seeing familiar names and great institutions and community-based organizations represented. I just really am honored. I'm Mishka Terplan. I'm a physician. I'm an obstetrician gynecologist. I'm also boarded in addiction medicine, and so my real clinical research, advocacy, and public health interests are along those intersections of reproductive and behavioral health. But my entry into this work has been, long in some ways. Like I worked in syringe exchange when I was in medical school. I set up a clinic that, actually a clinic for women who injected drugs that ran concurrent with a syringe exchange. But really, one of my areas of interest more recently is the intersection between this and the, family policing or, child welfare system. And my entrance to that, I have to say, is from following my patients and the people that, that I had the privilege serving. As they got involved, I followed them, sometimes literally, into court. And from that experience, I've, made contact, with lawyers and legal and policy people and things like that. But if it weren't for, the people that I was serving, my existence would have been, really blind to a lot of those realities. And I welcome this, look forward to this conversation, in particular, thinking about these intersections in, we see this post-Roe world as like it feels in some ways like this radical new space, but it's been there a long time for lots of people. It's but how this present impacts everything that we have experienced and bring to the table is we have to speak this.
Thank you so much. So I'm kind of thinking, let's set the stage. Like, what exactly are we dealing with? So anybody who wants to can jump in and answer this question. I'm thinking perhaps Mishka and Lauren might be the people to start, but anybody that has something to say, just jump in. So what happens? What takes place after a child welfare report is made versus maybe what people hope or expect might happen after the report is made?
I mean, I think so providers make reports, I would say, for two main reasons. One is because they recognize that this person needs services and they don't know how they think falsely to a large extent that the child welfare agency can provide those needed services. I think the second reason people make a report is because they're terrified that if they don't report, something horrible is going to happen to that newborn, and that they can't assess the safety. That's not in their training, so better offload that responsibility to, so to speak, to an agency. Then there are also people who report out of just frank malice, right? And in many ways, those first two can reflect that as well, that there's categories of people that are undeserving of motherhood, and that we're almost going to weaponize this, child welfare report system in order to punish them and in order to sort of continue what's been, a very, very long history of separating certain, infants from their parents. So that's, I think, the motivation. And I'll pause and let Lauren talk.
So I think it's really challenging because in an ideal world, right? Well, let me back up and say many of us are mandated reporters. So when we hear certain things that clients are telling us, we have to report them. And that, I think, brings up a lot of ethical dilemmas that I'm sure we're going to be addressing tonight. But I think what in an ideal world, like, they would be connected, the person would be connected to services, the child would not be taken out of their custody, and the services would be focusing on that parent-child dyad, right? Instead, for a lot of folks, there's people that are more vulnerable, and there's also risk factors for vulnerability in terms of, like, if you've had CPS involvement before and things like that. We're finding that especially women of color, people of color, are having their children taken out of their custody and placed with either a kinship placement or in a foster care situation. And it's really just replicating history, what we've seen in history. So I want to believe that a lot of providers don't know that side, because I think if they did know that side, we'd be having more of these conversations. And again, I'm happy to talk about this more throughout, the time that we have together. But it's advertised, if you will, or marketed as something that's really supportive, but in practice, it's not always that way. To simplify your answer.
And I just want to provide a little historical context to what Mishka and Lauren were just talking about. I'm going to link in the chat if folks are familiar with Dorothy Roberts. Her most recent book is called Torn Apart, and it explores the way that the child welfare system and the criminal legal system have worked to separate children from mothers who the state has deemed unfit for parenthood. And in a lot of Dorothy Roberts' previous work, she talks about how this phenomenon really echoes the behavior of US government public health officials who would go to native lands and perform similar actions, taking native children away from their parents and putting them in foster care with white Anglo families, or in, especially in Canada, in residential schools. So this is a practice that the United States has very unfortunately been engaged in against communities of color for, at this point, multiple centuries.
And when you bring up Dorothy Roberts' latest book, it just reminds me, a couple years ago, I read, I forget the exact title, but I think it was called The Color of Child Welfare, which she wrote like in the late 90s. And it must just be so depressing to be writing basically the same book about the same stuff that is happening in the same way 20 years later. Just really, really disheartening. So we need to step up, and that's what we're trying to do today. One thing that I wanted to ask that I thought of while Lauren was speaking, and I'm not sure which one, perhaps Benjamin might be the person to respond to this. Is there a big gap between what mandated reporters think they're required to do and what they are required to do? And how can we advocate for change to those rules which we know to be harmful?
So it depends on the state. That can vary by state. And the best advice I have to folks is make sure you know exactly what you're supposed to report, and don't ever trust anybody who verbally tells you this is what you have to report. If you really have to report it and it's mandated, it will be written down somewhere. The legislature, the agency, they have to write it down before it becomes mandated. And making sure you know exactly the bounds of those requirements will save you from reporting someone you think you have to when in fact you didn't. And not this, what I'm about to say is not legal advice, but one thing you might consider: what is the punishment for not reporting, right? Because laws are out there, they tell you what to do, but they don't punish you unless you get caught doing it. So, I forget things all the time. I'm a clumsy person, that email just didn't go through. Sometimes it happens to the best of us. Again, not legal advice, but knowing exactly where you do have to report and where you don't have to report will prevent you, let's say there's a clear reporting and a clear you don't have to report this. Somewhere between that, there's going to be a fuzzy area, right? And if you know exactly what's written down, what you have to report, we'll make sure you're only reporting in the clear area, right? So if you just group all the fuzzy areas over there with no reporting, that's, you know, probably the best way to go about things. But yeah, there is a gap between what people think they have to report and what they do have to report, often because they haven't seen the words written down on the page. And I think I saw in the chat, and I apologize, I didn't see who posted it, but it looks like somebody may have posted a 50-state guide. So hopefully that has links to the actual reporting requirements for individual states.
And I just want to add, I'm not a lawyer, but by any means, but 42 CFR Part 2 does apply in a lot of these situations, and I'm sure that's going to probably come up again. So just to echo what Benjamin was saying was that it is important for us, there's many clinicians on the call, to know also 42 CFR Part 2 and HIPAA, because there are times I think it's gray and we could be violating that federal law.
This is something that I talk about often in various groups that I'm active in. And I'm always asking the question, has anybody ever heard of anyone being punished for not reporting something? And I've never, as far as I know, and please correct me if you've heard of one, but there are no verified reports ever of anybody being punished for not reporting. So I think that's really important.
Yeah, I was going to write that in the chat. That's reflects my experience as well. But so there's like legal consequences, which I've never heard of. But there are people I know who have been, you know, reprimanded by their superior within a hospitalized setting for you know, not having issued a report.
Yeah, and sometimes I think we as healthcare providers and the people who, although we don't feel like we have a lot of power, we have more power within these systems than our patients, and it is our ethical duty to stick up for them. So now I want to talk a little bit about like where these ideas came from, these laws, these policies. So let's talk a little bit about how these laws that are ostensibly meant to protect women and children, how are these twisted and used in ways that they were not intended to? And can we look at some connections in the legal landscape about how the harm reduction and abortion movements are connected, how some of these laws are designed for something else entirely, but ended up being used against people who say self-manage an abortion or use a drug while pregnant?
I can chime in on this one. So there's a really tragic history behind fetal harm laws, which are weaponized against people who are brought in because either they actually did in fact attempt to end their own pregnancy or are just suspected of that. Side note is that there is no medical test that can distinguish between a spontaneous miscarriage and a self-managed abortion, which means that any pregnant person who is experiencing pregnancy loss can be targeted under the suspicion that they've self-managed an abortion in states where that is criminalized. So the history behind these laws that apply in that context and in the context of substance use during pregnancy was that there actually was a real intent to protect pregnant people from acts of violence during the perinatal period. So the idea was to bring up or sort of make harsher sentences for people who committed an assault or battery or an act of violence against a pregnant person than they would otherwise have if they had committed that same act against someone who wasn't pregnant. And so the laws were designed to protect pregnant people and their babies. However, what we're seeing now, like I said, is that they are being used in really creative ways by prosecutors around the country who are trying to punish the same communities that are disproportionately targeted and surveilled in other contexts: Black and Brown communities, low-income communities, people who are neurodivergent or have other disabilities, people who are experiencing houselessness, sex workers. We're seeing the same groups be disproportionately targeted by these sort of misapplied laws that who are targeted in other contexts. And so it's important to really understand the criminalization of abortion and the criminalization of substance use during pregnancy as being part of a continuum of laws and efforts on the part of states to deny certain communities who our culture treats as less deserving of full bodily autonomy than others. It's part of a larger web that is really consistently targeting the same people. And for those of you who have been attending the previous events, Joelle, I think, really aptly framed the initial sort of presentation by saying, the studies and the data that we have are looking at who gets caught, right? So it's not, it's really important to remember that the criminalization of substance use during pregnancy, the criminalization of abortion is the data that we have about, who does self-manage abortions and who does consume drugs during pregnancy is skewed by, who is getting surveilled and who is getting policed for those behaviors versus the actual general population of folks who are engaging in them. So I'll pause there.
And I want to add on to what Anna was saying by talking about, like, not only is it that the laws that are used to criminalize pregnant folks who use substances are the same laws that are used to criminalize folks who are seeking abortions. There's like a very clear through line of like state criminalization of healthcare services that defy heteropatriarchal norms. Like, this is the same mindset that is criminalizing gender affirming care. Like, this is the same mindset that's criminalizing abortion. Like, there's just like types of healthcare that at times the state will deem unjust or like undesirable. And there's like lots of different history of like governments going out of their way to prevent those kinds of care from happening.
Yeah. Oh, go ahead, Ben.
No, go ahead.
I mean, I just wanted to echo that and push back a little bit, like Joelle, on the assumption that some of these laws were designed to help. I don't think CAPTA sort of emerges from the ashes of attempted federal legislation to comprehensively address child poverty and really ends up pathologizing poor families, as potential child abusers. Within the CAPTA legislation, that the recognition, that babies come from the bodies of women and other pregnant people wasn't even acknowledged until, 20 years or 30 years after, the original statute. And clearly, but you don't need to have bad laws to, arrest, try, incarcerate somebody for untoward behaviors. In many ways, exactly what you were saying, Reagan, like this illustrates sort of the power of structural sexism and the strength of misogyny in society that continues to try to keep certain classes of people, in particular women and non-heteronormative folks in particular boxes. And it's you don't need laws to punish, actually.
And I certainly second everything that's been said so far. I would add, yes, there are, people who are acting with malice, but there are also idiots out there. And it's always nice to remember that there are idiots, including in the legal system. And having listened to a variety of prosecutors over the last 4 or 5 years, some of them, are exactly what you guys are talking about, right? So, they are acting with malice. They are trying to harm one individual or one group for their own, whatever reasons they may think are justifying this. There are also morons out there who think that they are helping, right? And so they will tell stories about how, a family comes up and thanks the prosecutor for locking their kid up because, this kid just wasn't going to get on the straight and narrow without being locked up. And that kind of mentality has carried over to certainly the substance use during pregnancy At least in Alabama, we don't have a specific law that criminalizes that. They're using Alabama's general assault law. And there are people out there who really think, wrongly, I mean, to be clear, that they are idiots for thinking this, but wrongly, that they are helping people by bringing these prosecutions.
If I could just add on to that too, in North Carolina, we do not technically criminalize during pregnancy, but what I have seen happen is a provider will document within the medical record, this person has ongoing substance use, please check the meconium, or like make a CPS report if the drug screen at labor and delivery is positive. And so I would say that, yeah, maybe on the books it says that, but there's ways around that. And unfortunately, that's happening more often, I think, than people realize.
Thank you for bringing up meconium and drug screening, because I wanted to talk about that a little bit with you all as well. In my experience, and I've been, I don't have quite as much experience as some of you, but I've been working in hospital perinatal care for 18 years. And I struggle to think of more than one time when a urine drug screen told us anything we didn't already know, or when we ordered a meconium test on a baby that we didn't already know. So when we look at our codes of ethics and our laws, and even like fraud, you are not allowed to bill Medicaid for a test that is not being done to inform clinical care. So if you know somebody is using a drug and you order a very expensive meconium test on their baby's poop, like, what are you hoping to get from that? In reality, we're not providing care with these tests most of the time. We are collecting evidence against our patients, which is just not cool. Anyway, I kind of went off on that one. I wanted to allow you all to have a chance to do so as well. I'm especially interested in, why doctors are ordering these tests and what happens, because from my perspective, I just collect the poop and send it to the lab. And then everything that happens is on the social worker end. So please, let's talk about that a little bit.
So yeah, briefly, I mean, I think drug testing in general and urine drug testing in particular is like overused, misinterpreted, and rarely of true clinical indication. There's a truism that part of medical school is only order a test that's going to change the clinical management of a patient, and also only order a test that you can interpret the results of. And I will say that there's a lot of ignorance around urine drug test result analysis. There's a small literature that actually shows that many people don't know how to properly interpret a drug test. That's true of meconium as well. And so things to keep in mind. I think this is a really good opportunity, though, for hospitals and clinics to come up with protocols. When what are the criteria for testing? And that if you're going to test, there needs to be consent, and we can problematize that, but leaving that aside for a moment. But the consent includes like information sharing. How is that information going to be shared, and with whom? And then the person has a right of refusal of the test, and that refusal should have no negative consequences on their care. There's all sorts of, it's a tool, right? A test is just a tool. It can be wielded well, it can be wielded poorly. Most of the time in birthing hospitalization, it's wielded poorly. But it in and of itself, it doesn't have value. We, in how we use it, give it value. All of that fraud, is a really fascinating dimension to explore. But for me, one of the intersections between sort of especially self-managed abortion and drug use in pregnancy relates to provider behavior around information sharing. And Anna can speak to this far better than I can, but my understanding is that almost every single case of self-managed abortion originated by a report that was usually a violation of HIPAA, among other things, and to policing authorities. And it's that same, and that's something we're concerned about in the post-Roe world, is how information, and because providers seem so ready, to overshare, and actually really unequipped to really understand the consequences of information sharing, much less to really involve and center the person they're serving, in permission seeking for that process.
Absolutely. And I also, unfortunately, want to say that that sort of lax attitude with privacy and like information sharing isn't unique to this context. There, like even within advocacy organizations, something that I've seen as like really endemic to is just like a lack of awareness about how having clients' information live on a Google Drive might potentially subject them to their information getting leaked in ways that that are putting them at risk. So yeah, I think privacy is, and like privacy connected with tech is like a huge piece of this. But then I wanted to say something linking what Benjamin was saying at the beginning in terms of like what should you be thinking about when you feel that impulse, like, oh, I should probably report this person. There are only 8 states that require you to drug test someone if you suspect that they're using drugs during pregnancy. That's a tiny minority. And even then, even in those states, those patients have a right to informed consent, which means they get to find out what the risks are. And I think that what any provider can do, even if you're in one of those 8 states where you do have to go through that rigmarole, is to really actually make informed consent more like affirmative consent, meaning you have done everything that you possibly can to make sure that this person understands the full scope of risks that are involved when they say yes to that drug test. And it's important also to understand that just because, like, let's say that there is no statute criminalizing self-managed abortion in your state, or there is no statute criminalizing substance use during pregnancy. Even if that's true, that drug test, once you've ordered it, in a little over half of states, you have to then sort of send that positive drug test, if it comes out positive, to Child Protective Services. And once that report has been filed, regardless of what the outcome is, that person is in that system. So where I'm living in New York, every state is a little bit different, but where I'm living, that puts that person into the system until their child turns 28 years old, which means that until that child turns 28 years old, that person and their child are going to be in a heightened state of surveillance from the government. It's a door into the literal homes, because a CPS report does involve an unannounced home visit, where we're literally talking about a state agent coming into your home and checking out whatever they think is relevant to the inquiry. And I think that it's important that when you're talking about consent for a drug test, that you are explaining that to the person that you're talking to. And if you don't feel confident in your ability to explain it, there are patient advocates and lawyers out there who love working with people to help them navigate their rights. Elephant Circle is one such organization. So I think that that's sort of another sort of thing to bear in mind as you're navigating that sort of impulse of like, do I report, do I not report? Just really make sure that you're looking into whether you have to test, whether you have to report that test once you get it back and it's positive, and make sure that everyone really understands what risks are entailed.
I just want to echo someone in the chat. I appreciate the language shift as well. with the informed consent. I also want to just add, since we haven't brought it up, ACOG and other professional organizations actually say not to urine drugs or use any biological, but testing like urine drug screens and blood work. They suggest, using a validated screening tool, which is either verbal or self-report, depending on the actual screening tool. So we're seeing professional organizations actually telling us not to do it as well, which I think is very telling that people are still doing it, even though the guidance is that we shouldn't be.
I have just like a prompt for the next kind of segment of discussion. I want to get into some of the key principles of harm reduction, specifically moving away from the idea that complete abstinence is the only way to treat a substance use disorder. So could folks talk about how programs that require abstinence and clinicians that require abstinence actually end up doing more harm to pregnant people who use drugs and people who use drugs as a whole?
Okay, I can jump in. So what I see clinically, I mean, I can't tell you so much of research except for the fact that people aren't getting connected to services. But what ends up happening with these residential programs or absence only, or these outpatient providers that are absence only, is that people aren't getting treatment. And, it's extremely harmful. People aren't getting MAT if they have opioid. We're not even, like, we're noticing in North Carolina from 2016 data, providers weren't even giving naloxone or Narcan kits. So I guess to say they're just not, and it's setting the people that are seeking services up, I hate to say this, but to fail, because you're limiting the option, what options that they do have. And what I've also seen, and I know we talked about CPS reporting, but what I have seen personally through my own work is that when people, if there is a report made, if people are connected to services and connected to treatment, the outcome is going to look much different than if they're not connected at all. And again, I'm reporting on old maternal mortality data from North Carolina, but what we saw was that people were turned away or kicked out of programs. And a lot of these people were the ones that ended up dying from overdose deaths. So I want to say the most serious consequences, we're losing so many people to this. So anyway, I hope others can add to what I've said.
Reagan, that's a great question. I think abstinence is one of these like intersections between addiction and abortion. Like the terms are used, both in, sexual health education and similar kind of paradigm, of what the, ideal world looks like. And as well as sort of lack of evidence. That being said, there are as many paths to recovery as there are people in recovery. And for some folks, abstinence is important. So I want to be careful about how we sort of separate out the heterogeneity and the humanity of recovery from the addiction specialty treatment services. There's been a lot of legal advocacy that has really changed the landscape, in particular residential care. A lot more work needs to be done. But generally speaking, many states now, many Medicaids are saying, if you are receiving money, like reimbursement from government services, you must offer, FDA approved medications. And historically, we encountered a lot of sort of abstinence ideology amongst family drug courts, amongst child welfare workers, amongst, even in drug court. And that has been slowly shifting, or in, residential programs within, the recovery, 12-step support communities. There's still resistance, but it's there. That's actually a space that I feel like there has been marked improvement. The term harm reduction is, it can be a little bit of a third rail in some sorts of contexts, but the principles, when you think about prenatal care and you think about management of diabetes and pregnancy, right? It's harm reduction. You know, somebody might miss a prenatal visit. We don't kick them out of prenatal care. We see them when they show up. They might be late. We try and fit them in. You know, their diet might not be, whatever. They're still eating some sugars and carbs, and we are adjusting their insulin. So I think, somewhere I'm hopeful that clinicians, why is it only in some disease states that we apply those principles and not in others? But I think, to me, it's like, yeah, it's not just meeting, people where they're at, but it's, supporting them to get to where they want to be. And that's really, that should be, that to me, that's what the work of like, the healing, professions are.
When you were talking about diabetes, it reminds me of cigarette smoking, which is substance use. And we have so much really strong data about how harmful it is for just people who smoke and also for pregnancy outcomes. And yet we have this wonderful harm reduction approach where we offer people help quitting, and we keep working with them if they're unable or unwilling to quit, and we don't take their children away. And so it's like we somehow we can grasp harm reduction for substance use for certain things. And I was talking with a group in Southeast Asia about this, and they were like, oh, they probably just do that because too many people smoke. It would be impractical. And that's exactly what it is. It's really easy to oppress and target smaller groups of people that don't have a lot of political power and don't have big tobacco behind them. So I always try to get people to be like, treat all drugs the way you treat cigarettes.
And I'll just add to that, we have data that like, even reducing by 1 cigarette a day has measurable, like population health benefit for, severity of neonatal abstinence syndrome, weight of the newborn. And that same principle, like is not unique to like, combustible, like, tobacco plant. It's like, across other sort of substances and behaviors.
It's almost like incremental improvement is like a thing. But I want to, let's keep this going. We have about 10 minutes left. Folks, if you have questions, go ahead and put them in the chat and we will do our best to get to them. In the time we have left, I'd love to focus on practical strategies that we as service providers can use to help our patients protect themselves before, during, and after an incident, as well as, if we have time for it, what can we do to protect ourselves in these systems? I think there was one person up there who was saying punishment doesn't always come in the form of legal sanctions. And I think it was Mishka who said you can be punished by your institution, even though you're not doing something legal. And for me personally, it's always hard to weigh, like, how far can I stick my neck out without getting fired? And so let's talk a little bit about what the individuals can do who are caught up in these systems and what we as service providers can do as well.
So in terms of what individuals can do, and again, I'm not trying to be overly adversarial, but I'm a lawyer. I say many things that make a lot of people uncomfortable. But as you think about this, you mentioned Medicaid won't pay for drug screenings, right? Which means if you know that what's going to happen is a drug screen, that is a False Claims Act violation. You can take that to the government and they will sue. And it is a huge, huge, huge deal, right? If you go to your general counsel's office and say, hey, Dr. So-and-so is ordering all these tests that violate the false claim, not the False Claims Act, but it's fraud, we can be sued, right? That tends to mean you don't have to stick your neck out because now you have a threat going the other way, right? Same thing with informed consent. If you violate someone's informed consent, that is tort liability. You cannot test someone against their will unless there's a statute saying you can. So I'll let the real clinicians, I'm not a clinician at all, even a little bit, talk about how you can stick your neck out in other situations, but just legally, right? There's always something on the other side. You're being, you can remind your doctor, you can remind your supervisor, you can remind your general counsel, hey, we could be on the hook for millions of dollars if we do this. So how about we just, not do this?
And I would advise people to use the anonymous tip line, because I have been fired for making that report about Medicaid fraud for unnecessary testing. So that was my personal experience has informed this question. So yes.
Did you file a wrongful termination suit? I hope.
No, because, okay, I will be quick. If you are going to go after your institution or your employer, go to a lawyer first before you take any action, because I tried to go to a lawyer after I had already been fired, and they were like, we need you to collect these documents and this stuff. And I was like, well, I don't work there anymore. They won't let me on the unit. So use the anonymous tip line. And if you see something, prepare beforehand, because once you're out of that system, you're not going to be able to have access to the stuff that you would need to win a case. Or at least that's what I was told by the whistleblower lawyer agency.
All of that is accurate. And if you're going to make the threat, I'm going to do something, if they catch you printing stuff off to take home, right, that tends to scare them into not doing things in the first place, right? Because they don't know how much you already have. And it doesn't take that much, especially if you have the government involved. And I saw a question on the informed consent. It can be a he said, she said type thing. I think that's what they said, he said, she said. Yeah, it can be that situation, but the way that medical malpractice works, and this is depending on what state you're in, it might be a medical malpractice claim, it might be a battery claim, which is an intentional tort. Hospitals, doctors get punished as soon as the demand letter is sent. So even if you don't win your claim, their premiums are going to go up, because the way that medical malpractice insurers work is anytime they have to defend you against a claim, which starts as soon as that demand letter is sent, they put that in your file and that sticks with you forever. Anytime you go to get new insurance, that's going to stick. So that raises your premium. So even if you don't get any money, right? And since you're the clinician trying to avoid having something bad happen, you're just trying to make the threat. You might want to point out your premiums are going to go up if you do this. So perhaps we should not do this.
Anybody have practical tips that we can give to our patients before, like what to do to protect yourself before going in to these vulnerable institutions, what to do in the moment, and what they can do afterwards?
I think really zeroing in on the fact that there are these informed consent laws in all 50 states. I'm popping in the chat a really useful resource from the Birth Rights Bar Association, which outlines a person's rights during pregnancy and labor and delivery. And there is a specific chapter that is directly sort of addressing the rights of pregnant and birthing people who use drugs. And I think that, yeah, just really sort of honing in on the fact that you can always say no, and that if a provider is suggesting otherwise, or is like, sometimes it happens where people are physically restrained and forced to undergo testing that is non-consensual, that they have that they have a right to talk to a lawyer, and that you know, in many places there are also there is a legal right to have a patient advocate who can work with you to advocate for your right to refuse to undergo the drug testing treatment. Same applies for HIV testing during pregnancy. And yeah, just really sort of honing in on the fact that they do have that human and civil right to refuse medical care. And then in terms of like what providers can do, medical licensure boards exist in all 50 states. And if a provider is violating their obligations under HIPAA or what have you, that is an avenue for accountability. It's not a great one. There are not, unfortunately, a lot of instances where accountability has been achieved through that avenue, but they exist. And then I also wanted to just name the fact that HHS, the Department of Health and Human Services, just this week closed the period for notice and comment on a new rule that is clarifying and expanding the scope of non-discrimination protections in the context of healthcare. And there are a lot of really specific provisions looking at pregnant folks and discrimination on the basis of pregnancy status, and clarifying the obligations that healthcare providers have to not discriminate against people who are pregnant or people who have disabilities. And substance use disorder is a disability under the Americans with Disabilities Act. And so I think that, and there's the point I was going to make is that there is a complaints portal on OCR's website. The Office of Civil Rights of the Department of Health and Human Services has a free complaints portal where you can go and you can file a healthcare discrimination complaint. Anyone can do it. You don't have to be a lawyer. It's a mechanism that not a lot of people know about. So yes, I will drop lots of resources in the chat for filing those complaints. But yeah, those are a couple of things you can do.
Those are all awesome, and I dropped a link to JMAC for Families has a resources for people affected by the child welfare system as well. I think two things. So all of this is great, but I think we have to think about discrimination as a patient safety issue. And that's a way to kind of bring together, because it harms, people, it harms outcomes, it increases liability for institutions. And it's really, a patient safety issue. And there are, there's the the perinatal quality collaboratives that are focused on, making birth more safe. Some of which have taken on, SUD as a topical area. Those can be sort of organizing principles. So what healthcare providers can do, I think it's really important for the child welfare piece to interrupt or at least pause the process, before a report is made. And people have, been trying to work really like a brief clinical protocol that is a, child welfare timeout. Before a report is made, let's convene, the perinatal social worker, the pregnant person or postpartum person, whoever they deem to be present, a clinician, and discuss what's happening before we automatically, reflex test and report. I think you can, depending on your, kind of power and privilege, and recognizing that is unequal, across people and across workforce. Some of us inhabit greater positions of power within institutions, and we can, leverage that, to serve betterness. And then think about what are the policies and procedures in your local. Look at them, through the lens of, the people that we serve, and convene, a group to better them and include people and support them, with lived experience or who are affected by child welfare in the sort of development and then the evaluation of those protocols.
I was actually going to mention the harm reduction doulas. I want to also take a different approach to this. I think that there's a lot to this question, and I know we're at time, but I do think doulas play a really important role in this. It takes a village, right? And we didn't get to talk about this tonight, but part of the reason I would say a good chunk of people are using substances because they are isolated and alone and don't have support systems. So anything that we can do to help build that natural support system, and a doula is just one of the ways. I also appreciate that doulas are not clinical. So I think that they offer this unique perspective. And that's awesome that y'all are sharing that. And I also want to advocate for peer support. We need more perinatal substance use disorder peer support specialists that have lived experience, because they can help navigate. They can also help validate their experiences. And I would say that a lot of the peer support specialists that I have been fortunate enough to work with know the system better than any of us, because they've been through it. So I think encouraging more kind of peer support, funding for peer support, is really essential to this process.
I think we're gonna have to call it there. I could listen to each of you for like hours and hours more, and I hope I get to soon. But we're gonna call it there. It's 1 minute past. Please, everyone, we're gonna Reagan, I think we can share the chat as well, just because there's so many amazing resources that got dropped in there. I also, for folks that want to DIY it right now, you can just like highlight it all and Control-C and then plop it in a Word or text document. I've done that before. But thank you so much for being here. Thank you so much to all of our amazing speakers and to Reagan for doing all the behind the scenes organizing. And I hope that I hope to see you all again. I hope our paths cross often. Thanks.
And before we go, I just want to plug our next event in there. We're doing an event on trauma-informed care as applied to HIV or HPV testing and cervical cancer screening. Just looking at the ways that disabled folks, queer folks, survivors of violence avoid getting pap smears and avoid speculum-involved pelvic exams as a whole, and how that contributes to disparities in HPV testing and cervical cancer early detection. So if that's something you're interested in, we have our upcoming training on that. So I put it in the chat. And thank you everyone so much for being here. We really appreciate it. Bye y'all.